Okay, everyone, thank you for joining us today for Whole Grain and Diabetes, Reducing the Risk and Implications to Healthcare. For those of you who are unfamiliar with Oldways, Oldways is a nonprofit dedicated to improving public health by inspiring individuals and organizations to embrace the healthy and sustainable joys of the old ways of eating. We're most well known for creating the Mediterranean Diet Pyramid in partnership with the Harvard School of Public Health, as well as for creating the Whole Grains Council and Whole Grains Stamp. The Whole Grains Council is a program of Oldways. We help consumers find whole grains and understand their health benefits. We help manufacturers and restaurants create more and better whole grain foods. And we help the media to write accurate and compelling stories about whole grains. Again, you may also be familiar with our whole grain stamp, which is the packaging symbol that displays the gram amount of whole grain in one serving of the product. So we have some really wonderful speakers lined up for you today in this webinar. So I just wanted to go over some housekeeping notes first. The video recording and the slides will be posted on our website within 1 week. You will all receive an email within 1 week with the recordings, the slides, and the CPEU certificate for registered dietitians. We will have time to take questions at the end of the session. So please use the Q&A function in Zoom to type in your questions, and we'll get through as many as we are able. So again, hello everyone, and welcome to today's webinar, Whole Grain and Diabetes, Reducing the Risk and Implications to Healthcare. This webinar is sponsored by the Bell Institute of Health and Nutrition from General Mills. If you're not familiar with the Bell Institute of Health and Nutrition, they are a dedicated group within General Mills whose mission is to be the source of scientific health and nutrition expertise for the company. They believe food should make us better, so they work hard to make food the world loves. So we have two really excellent speakers joining us today. The first speaker for today's session is Dr. Kevin Miller. Dr. Kevin Miller is a principal scientist in the General Mills Bell Institute of Health and Nutrition. In his role, Kevin is responsible for ensuring that General Mills products comply with external and internal nutrition regulations and guidances. Kevin also provides input to key company stakeholders on multiple nutrition topics, including whole grain, carbohydrates, fiber, protein, and fortification. Previously, Kevin worked as a scientist in healthcare nutrition, studying nutrition interventions for improved patient health outcomes. In both current and former roles, Kevin has maintained his passion for building healthy dietary lifestyles that improve overall public health. Our second speaker today will be Dr. Sarah Grafenauer. Sarah Grafenauer is the discipline lead for the new Masters in Dietetics and Food Innovation program at the University of New South Wales in Sydney. She is a fellow of Dietitians Australia, a member of the governing board for the Whole Grain Initiative and the Oat Council of Australia. Stemming from her previous role managing the Grains and Legumes Nutrition Council, her most recent research focuses on food systems, whole grains, and legumes. Sarah maintains a private practice where she consults with a large range of clients. And so with that, I am going to hand it over to Kevin. Thank you so much.
And Kelly, if you can hear, or Sarah, if you can hear me and give me a thumbs up. Great, thank you. So thank you, everyone. Let's see if I can advance the slide here. So for transparency, as Kelly had mentioned, I'm an employee of General Mills through our Bell Institute of Health and Nutrition. But it's a great opportunity today for us to talk about whole grain and diabetes. As you may be aware, today is Global Diabetes Awareness Day, and tomorrow is International Whole Grain Day. So it seemed like a great opportunity for us to talk about the relationship between these two. And I'm hoping that's going to advance. There we go. So for an outline, I think it's important for us to talk about the state of the union in regard to diabetes, specifically in America in this case, and then move on and speak about the dietary guidelines for Americans' recommendations for grains, both whole grains and just overall grain intake and what the implications are. Speak about grains, fiber, some of the phytonutrients, and then the impact that they have specifically on diabetes risk. Then we can also speak about whole grain foods. After all, people don't just eat whole grains, they eat whole grain foods, the impact of processing, and then some endpoints relevant to diabetes. You're going to hear some things today that are going to be a little bit contradictory at face value. So we're going to spend the very end here sorting out some of the confusion in the science, and that'll help us to draw our conclusions. So the numbers that are provided here came from a recently published Center for Disease Control National Diabetes Statistics Report, and they're estimating 130 million people in the population have diabetes, and that's almost 40%, which seems unbelievable. And that between 117 and 123 million of those people are type 2 diabetics. So as a result of that, for all intents and purposes, the remainder of the talk today will really focus only on type 2 diabetics, not on type 1. And it's important for us to recognize that minorities have the highest percentage of diagnosis of diabetes. And that of those adults, those with the family income that's below the poverty level, in other words, the lowest socioeconomic status individuals, have the highest prevalence of diabetes. And then lastly, and not surprisingly, because they're related, the lower education levels are also more likely to have been diagnosed with diabetes. And the reason for this and why it's important to us is because whole grains offer an opportunity for us to be able to have nutrition solutions for people to manage and maybe even help to reduce the risk of diabetes based on what we see in the data. So if you go into a store recognizing that whole grains and refined grains typically do not cost much more for the majority of those products. So it can be a solution for people such as those listed here. The Dietary Guidelines for Americans recommends that we eat fruits and vegetables and whole grains. But the problem is Americans don't walk into a store and say, I'm going to buy fruit, I'm going to buy vegetables, I'm going to buy whole grain. They buy apples, they buy grapes, they buy carrots, they buy lettuce. And for grains as well, they buy wheat bread, they buy oat cereal, all of these different things. So the Dietary Guidelines for Americans are not really specific enough to help us understand the implications of our diets. However, they do assume that there's going to be a variety of these different foods consumed. And that's necessary for us to be able to derive the very broad benefits that the different grains can impart. So in regard to diabetes specifically, this is a new study that I found quite intriguing. So they looked at the association between individual whole grain foods and type 2 diabetes risk. And the reason I find this study so intriguing is that it is developed from data collected from the Nurses' Health Study. And if you're not familiar with this, it's a study that currently has included 160,000 women and nearly 40,000 men, and they followed them over a period of average 24 years. So this is a prospective cohort study. They enroll people, they follow them over a period of time. When these people were enrolled, they did not have diabetes, cardiovascular, coronary heart disease, or cancer at that baseline. And then they looked at over the period of time at their whole grain food consumption patterns. So on the far left, we can see there, those people who reported having 0 to less than 1 serving of those foods per month, and then 1 serving a month up to 1 a week, and then increasing frequency, a serving a week up to 6 servings a week, or even those people who reported eating at least 1 serving per day of those foods. So for the whole grain ready-to-eat cereals, we can see that those people who were frequent consumers, between 1 and 6 servings per week, they had a nearly 33% reduction in the risk of developing type 2 diabetes during the period that data have been collected. For dark bread, I know that's a strange terminology to use. It's a whole grain bread. The authors just chose to call it dark bread, that we see at approximately 23% reduction. Now, what's intriguing here, though, is popcorn. What we see within popcorn is that it's reporting that as frequency increases, they were actually showing an increased risk of type 2 diabetes. Now, the results may very likely be confounded because what are the things most commonly consumed with popcorn? Sodium, butter, maybe some other flavoring oils. So as a result, we don't know whether the authors were able to discern these differences or not, but it is at least a noteworthy change from what we see in like the whole grain ready-to-eat cereals, or even the oatmeal or the brown rice that are shown in data below there. And that whole grain benefits are often attributed to the fiber, but we do understand that there's more to it than just that. So dietary fiber benefits, just in general, they include improving gut function, they can promote satiety, they improve the quality of the diet, and that could be reduction in fat or having the decreased energy intake, but also with glucose metabolism. So different fibers can have different benefits. So if we look at these two examples, let's talk about cereal fiber versus fruit fiber. A study looked at insoluble, non-viscous cereal fibers. An example of that would be like beta-glucan versus the soluble, viscous fruit fiber. And an example of that would be like pectin. So if you've ever made jam and it wasn't setting up, you add the pectin, that's going to increase the viscosity and cause that to set quite a bit. And in this study, they looked at amounts that are typically consumed, and the cereal fiber was more protective than what they found for fruit fiber in the development of type 2 diabetes. So trying to learn more about this, what are the different mechanisms? Well, we know that cereal fiber can help modulate gut microbiota. So what do I mean by that? When we feed these cereal fibers to bacteria in the gut, they ferment those. So as a result, if you're feeding the right fibers, those bacteria that are often associated with improved health, they actually are going to be better fed with those fibers. They're going to grow in their population, and they're going to outcompete the less helpful bacteria in the gut. We also understand that these fibers can help improve glucose tolerance, and they do so because those fermented fibers are being created into the short-chain fatty acids like butyrate. And the butyrate's the number one fuel source of the epithelial cells lining the gut. So this can help to reduce inflammation. We see less of the C-reactive protein and things like interleukin 6 and 8, I believe. And then also it can help to improve the immune response. Now, this one I scoffed at when I first read it, and I read a little more before including this one, that the reason for this is that these cereal fibers are fermented. The short-chain fatty acids improve the health of the epithelial cells in the gut. And as a result, those cells are closer together, and there's less opportunity for some pathogenic bacteria to sneak in between. And therefore, they consider that to be an improved immune response. Now, as I mentioned with the dietary guidelines for Americans, we don't just eat whole grains, we eat whole grain foods. So it's interesting to understand the impact it may have relevant to diabetes. That processing of whole grain can impact a food's glycemic response. So in this recent study, they looked at less processed whole grains, and in this case, traditional oats, brown rice, and they compared that to very finely milled whole grain. And that might be more similar to like the instant oats that you'd find in some of those sachets, or a brown rice pasta where it's been ground up and made into an extruded product. And they looked at these two interventions on a variety of blood glucose related outcomes. So they looked specifically at the overall meal, the incremental area under the curve. And if you're not familiar with that, you've seen those bell-shaped curves of blood glucose after eating a food. So the incremental area under the curve represents how much blood glucose filled up that curve. Was it tall and what was it wide over that 2-hour period? And we see that the finely milled whole grain foods like the instant oats, that those actually did have a higher incremental area under the curve. In other words, there was more blood glucose. That's not surprising. When we think of what happens when we do milling, we're breaking down that structure and we're causing those starch granules to be more readily available, and therefore they're digested. Starch is made of glucose, and that's giving us the blood glucose. But what they did not report in here was that the hours above the range were any different for the finely milled and the less processed whole grains. So therefore, blood glucose did not go up so high. It was more readily available, yes, but it was not going and raising blood glucose in the hours above the range that would cause for concern. Now, the mean amplitude of glycemic excursion was also measured, and they showed a numerical difference. But for those who work in the field of diabetes, you may be able to assess whether or not that's biologically relevant. Is that difference that great? Now, what did surprise me, I shouldn't say it surprises me, but in regard to body weight, that the less processed whole grain, the people on average lost half of a kilogram during the period of the intervention, whereas those on the finely milled whole grain actually gained almost half of a kilogram. But again, this shouldn't be surprising because of the fact we said before. There's more energy available because that starch is now available. And as a result, with more energy available, people were more likely to gain weight. So this was another study, very similar, and the glycemic response between the degree of milling was interesting in how they compared whole grain and refined grain and found that the incremental area under the curves may not be different. So for this study, they looked at several different portions of the grains. They looked at a cracked wheat, and what's interesting here is the particle size. So that's telling you the size of the sieve that the flour could pass through. So for example, there was a mix. There was a combination of particles in cracked wheat between 180 and 1700 micrometers. So the size of that's not really relevant, just in comparison to each of the others. Semolina is the type of flour that's used in making pasta. And the 425 would indicate it's kind of a medium size. Now we look at these others, the whole grain wheat flour, refined grain wheat flour, reconstituted with bran in there, or reconstituted fines that has a finely grained ground flour. And what we see in the first two is that they had the lower incremental area under the curve, but those, whether they were whole grain or refined grain, were much higher. Again, not a surprise, because now we have broken down those starch granules so they're smaller and they're more available for energy. So as a result of this, WHO recently came out with draft guidelines on carbohydrates, saying that the WHO recommends that people get their carbohydrates from whole grains, vegetables, fruits, and pulses, and that this was a strong recommendation. And what we mean by that is they felt the data were very robust. And they wrote in here that because the evidence suggests naturally occurring structure of intact whole grains as part of the health benefits, that really lowly processed whole grains are preferred. But then later on, they admitted that the plant-based foods may contain a variety of compounds, some of which are anti-nutritional. So think like phytate. Phytate in plants can bind minerals very strongly, and it's only the processing that helps to break them down. So therefore, they recognize that preparation methods, and they also described heating, soaking, germinating, and fermentation, are all helpful to reducing the inhibitory potential. So we can see now that processing can make starch more available, which can cause more glucose, but it can also liberate other nutrients in there as well. So an example of that, and this came out of some study out of Purdue University, was they looked at the impact of milling and of puffing of different compounds, specifically oats is the one that I think they were looking at in this. And they found that by doing this processing, that fiber structure could be disrupted a bit. It's still fiber, it still has the benefits of fiber, but it was breaking some of those chains up in there. And when they did that, these antioxidant compounds like camaric acid, ferulic acid, and some of the, I think, avenanthramides were released. So you're actually increasing the available antioxidant capacity of the body when it was being fed the grains that were being processed. And the reason that this can be important is we understand that fiber can help to slow the absorption of glucose into the body, but it's also the benefit of the fermentation to the short chain fatty acids, and that some of these specific antioxidant phenolic compounds can actually help to slow some of the glucose transport as well. So on the left side there, we can see a picture showing the lumen of the intestine. Fiber kind of puts a mat or a blanket over those absorptive fingers between the food and your gut lining, and it can slow down that absorption of glucose at the transporter there. Another one is some of these compounds, the phenolics specifically, can actually, when they're absorbed, they can slow down the glucose transport from the epithelial cells into the bloodstream. And then once the glucose is being carried through the blood, insulin is triggered, insulin gets onto the receptor of the cell, and the cell responds by putting glucose transporters on the wall, and that takes the glucose out of the bloodstream and into the cell for utilization. Phenolics can also help to modulate that, and we see that they have antioxidant properties too. So the reason I said some of the science here can be confusing is I've just described to you how the processing impact of these can actually increase the glycemic response of these, but that yet we're recommending that whole grains, regardless of whether or not they have been processed, that they should still be consumed because of the health benefit to be able to prevent the development or at least reduce the risk of development of type 2 diabetes. And the reason for that is we're asking questions using two different types of science. So when we're talking about like the glycemic index or glycemic response of a food, those are randomized controlled trials done in a very small group of people. And you're only going to be looking at one or two modifiable nutrients, and you've assigned those people that diet. So for example, in this, we might assign whole grain versus refined grain, and we would look at something like the glycemic index or the glycemic response of those foods. It's appropriate to compare between those two, and that we can make some type of a informed decision on what recommendations should be made for an individual. But now this prospective cohort study, like I talked about the nurses' health study, that's where they're looking at what people have done. It's their dietary lifestyles, like whole grain or the refined grain. And it's appropriate to compare between the two of those, but it's not appropriate to compare between randomized controlled trial results and prospective cohort trial results. That's why the prospective cohort trial results are very useful in developing nutritional guidance for general populations, often including healthy people. So as a result of this, we've got some of our conclusions. We recognize that the research has shown pretty conclusively that whole grains can help to reduce risk of disease like diabetes, cardiovascular, coronary heart disease, and even certain cancers, specifically gastric cancers, and that whole grains contribute nutrients. And we're really focused here about like the cereal fibers and the phytonutrients when we're thinking about inflammation and diabetes. And also that the scientific conclusions about whole grain and diabetes may appear contradictory, but we have to consider that glycemic index and glycemic response of a food is not the only determinant that we should be making when we're making food recommendations. Milling of whole grains does definitely increase the bioavailability of the starch, as we would expect. And therefore, for diabetics, for those of you who have clients, those of you who have people in clinic, you consider the serving size of those foods around the whole grains so that the glycemic load could be an important variable in determining their diet plans for those people who are actually actively managing diabetes. But that whole grains, regardless of whether or not that it's been milled, still can be an important source of many of these nutrients, especially cereal fiber, but also some of those phytonutrients too. And that's what we believe actually reduces the risk of developing type 2 diabetes over time. So I very much look forward to comments, questions, discussion, and at this point would encourage my colleague to take over the slides and continue on with the presentation. Thank you.
Thanks, Kevin. That's great. And so good to hear about all those sort of mechanistic studies. And I'll just make sure that my slides can move along here. Oh, yes, probably a little too quickly there. So welcome and thank you for being online for this presentation this morning. I'll be talking to our healthcare cost savings research, and this really came out of some frustration around talking to some quite high-level leaders around whole grain and needing to be able to put more to the story around whole grain rather than just the nutrition benefits and the health outcome benefits. Actually put a monetary value on the change to consuming more whole grain in diets. And so I'd like to acknowledge the work of my co-authors, Mohammed Abdullah, who's at a university in Kuwait, and Jamie Hughes, who was my colleague at the Grains and Legumes Nutrition Council at the time. So we'll be working through a range of topics, looking again at that whole grain, and I'll take you through the more complicated way that we looked at this area of nutrition economics and how we derived the dollar values from the other data that we hold. And also talk you through prioritising whole grains and those simple swaps that we can make and look at some gaps in terms of policy. Because I still work in private practice, my work means that I'm still hearing from clients and consumers around their struggles with their diet and the range of diets that are promoted out in the media. And so hopefully I can lend some guidance there. So in terms of diabetes, I feel like my practice has very much changed. There's 1 in 5 people over the age of 75 that have diabetes, but my clients now are far younger, and far more of my clients have very complex conditions, and diabetes is just the icing on the cake. Most of our diabetic patients do have type 2 diabetes, and in 2020, it was the 7th leading cause of death in Australia. There are far more Americans with diabetes. It's about 1 in 10. And I know these figures actually are slightly different to what Kevin has presented, and perhaps my numbers are a little bit low there. So with World Diabetes Day on our doorstep today, we need to look at this issue, and then Whole Grain Day tomorrow. It's an important opportunity to look at the marriage between these two issues. And for me, really, the big issue is that it's not just about the numbers in terms of diabetes, it's about their care has become increasingly complex. So when we look at a whole grain, we've got these different components, and we can see that, while we have the starchy endosperm, that sort of white, but where we derive the white flour, there's still some really key micronutrients in that part of the grain. And then we have the bran, which has a whole range of micronutrients and phytochemicals that we may forget about when we're talking about the bran. We just consider it dietary fibre. But there's a whole range of components in there that are having health effects. And then the germ, the fatty part of the grain, again, some really powerful phytonutrients that are going to be having an impact on the body when we're seeing these consumed, particularly over the whole course of life. Together, we look at this more as a nutrient bundle. So often whole grains are omitted from food standards because they're not one nutrient or another, but together they actually are providing a whole range of these nutrients that are quite powerful in terms of health. Dietary guidelines since 1970 have included wording around whole grains and inclusion in the diet, but we're still sitting way below targeted amounts at around 20 grams of whole grain each day. And we'd really like to see that increase over time. Part of this research was around looking at disease outcomes, and I'll take you through the variety of areas that we've looked at. But the whole grain has important effects on cholesterol levels, triglycerides and glycemia, as explained by Kevin, but also antioxidant and anti-inflammatory type factors. And there's a range of areas in terms of health outcomes that we can look at from consumption of whole grains. So I've already mentioned why nutrition economics. For some part, it was really about gaining the attention at more political level around the power of whole grains within the whole diet. Our dietary guidelines are under review here in Australia, and so it's an important time to look at what foods are really helping us with risk reduction. The calculations leverage existing research in terms of risk reduction, but also the treatment costs in terms of communicable disease we know are increasing. The other part of the calculation that we've used is around the human cost and lost productivity due to disease. We all know that when patients are unwell, they are also missing days of work and missing out on opportunities in terms of their quality of life. It's politically astute to look at nutrition in this way. Often as dietitians, we can talk about the disease reduction and the benefits in terms of health, but putting a dollar value really takes the message home in terms of what we can do for policy change. And that's so important when we're at this point, when we're looking at a whole range of issues globally in terms of the way we're eating. It's not just about health, it's also about sustainability issues in terms of diet. The other point of this research is it provides a snapshot, so we can look back in time and look at how we've performed. And that's also really important. We've published a range of papers now. This first one looking at cardiovascular disease and type 2 diabetes based on Australian data, and also total cancer and colorectal cancer. I'll take you through this Finnish research that also focused on type 2 diabetes. And there has been a paper on the US based on cardiovascular disease. And then together, the US, Australia, and Finland has written a paper that combines the analysis to look at a 3-country approach. So they're all available for you online. In terms of the methodology, as I've indicated, we've used a range of publicly available sources. So firstly, consumption data. Our data in terms of consumption of whole grains is starting to get a little old in Australia, and we're looking forward to new data. But this was based on a paper by Galea, and we had a consumption level of 21 grams a day. We've also looked at cost data from the Australian Institute of Health and Welfare, and from there we can get our healthcare costs and our productivity losses. So these were built into an algorithm. In terms of the risk reduction data, there's a range of papers that we can look to see what's happening in terms of disease. But the big one for us and for today is to look at that 32% reduction for type 2 diabetes. And this came from those observational studies that Kevin has mentioned. We combined in the paper a look at cardiovascular disease, so that's also important to just note there. Our results. So when we're looking at the combined data for 100% of Australians consuming 3 serves of whole grain foods across the day, so this is as simple as a bowl of cereal and 2 slices of bread, or any combination of whole grain foods, and I'll take you through that. We're looking at about a $750 million saving. But that is based on universal immediate adoption of this change in the diet. And we all know that with behaviour change, that's not possible. And so we looked at a range of increases in whole grain across the population. Our big headline when we went to market with this research was 1.4 billion in healthcare cost savings. But I found that that sort of fell a little bit short of what people were wanting to hear, and consumers really questioned, well, how does that help me? So the other factor that we built in was a discounted rate, because we know that over time, $1 today is worth less tomorrow. And we knew that it was going to take time to make this change. So the Australian government has a proposed discounted rate of 7%. And we needed to apply that to get closer to the real dollar figure that we were talking about. And so when we looked at an almost 20-year proposal in terms of incremental adoption, so adoption over time, we were looking at $1.1 million, almost $1.2 million in terms of $billion rather, in terms of savings just with type 2 diabetes. But again, 20 years, are we going to wait that long to get this sort of result? And so what we needed to do was actually look at what would happen if we could adopt that more quickly. And it's something like triple the amount of savings if we could do this more quickly. And this is where this research really hits the road, because what we're wanting to do in terms of nutrition is actually show policymakers that if we could make change more quickly, there would be a much larger return on investment in terms of savings against healthcare. But that's really not all. When we're looking at communicating this result, it's not just about the dollars, it's about the people. And it's about the fact that we could really be saving a whole lot of people from progressing to type 2 diabetes. Or it could be a combination of both, right? We could save money and also prevent a whole lot of people getting diabetes. The Finnish work is actually really interesting. They proposed 3 scenarios. Now, this is a population with a dietary pattern a little bit different to the US and to Australia. They're eating those heavier breads made from whole grain more traditionally in their diet, and their intake of whole grains is far higher than either of our countries. So they looked at 3 scenarios. One where the proportion of the population increased from 70% to 80%, just consuming that 1 serving of whole grain each day. And then they looked at a proposal where the same amount of the population, the same proportion of the population, increased to 2 servings a day. And then they looked at a combination scenario where more people, more consumers were consuming that higher number of whole grain serves in terms of type 2 diabetes. They were also looking at quality of life, and I think that also points to some differences in terms of the research they were able to conduct. So you can see there on the slide, they also looked at this staggered model where at 10 years, it was something like 8.3 billion euros, and at 20 years, that amount more than doubled. In terms of quality of life, this is quite phenomenal in terms of the quality adjusted life years that could be gained through that decreased type 2 related morbidity and mortality. The interesting thing was when we worked together, the lead author from this paper, me from Australia and Kevin from the US, we looked at the differences in the way that we'd done this health cost saving research and the differences in the numbers and how we got to those numbers. This population is far smaller than the US. It's more equal to the population of Colorado. And so the estimated cost savings for this smaller population was something up to $4.2 billion. And remembering that their natural intake of whole grain is far higher. So when we look to extrapolate this to the US, where the population is just far greater, again, 59 times Finland's population, we're looking at estimating off these numbers much bigger savings for the US population, something like $64 billion as an extrapolation based on that 1 serving of whole grain. Imagine if we could really do this and it wasn't just a proposed idea, and the amount of money that we could actually then put into advertising promotion of consuming whole grain in preference to refined grain, and the return on investment that could be achieved from that. It's really about using this research now, and we're taking this to other conferences globally to really look at how we can speak to policymakers to help them see that this is a really important dietary change. When we look at the global burden of disease, sodium might be the leading issue, but diets low in whole grain are the second leading issue globally. So we know that this is an important message to take around the world. Healthcare has become increasingly complex. As clinicians, we've been dealing with a whole range of new issues. During COVID, we were running technology-based consults online. We're looking at medication shortages around the world for some of the new medications, the GLP-1 agonists. We're looking at longer-term management and care of our patients because they're being diagnosed with diabetes much younger. We're looking at physical and mental health issues. I don't know about you, but my clients don't come along with just type 2 diabetes anymore. There's a range of gut issues, there might be disability in the background, and there's certainly a lot more mental health issues. We need to look to cross-disciplinary management and really long-term lifestyle and behaviour change issues that we need to try and have them change. And this is making our practice far more complex. We're trying to do more in the same amount of time and possibly for the same amount of money. We know in Australia, when we've asked dietitians about whole grains, they don't necessarily prioritise them in practice. But we've got a couple of different angles that we really want to emphasise with you today. There's this prevention angle around type 2 diabetes, cardiovascular disease, and importantly also colorectal cancer. But we've also got management of disease. And glycemic control isn't the only thing that we're looking at with a patient with type 2 diabetes. We know that all clients with diabetes are at more risk for cardiovascular disease. And this is where we need to marry the observational research with the randomised controlled trial research. Although randomised controlled trial evidence seems to be quite heterogeneous, which means different grains are exerting different effects in the body, we need to look at the grain types that are having an impact. And we know that oats and barley are really useful in terms of that beta-glucan, helping to lower total and LDL cholesterol. But things like brown rice have been shown to lower triglyceride levels, which are also an important part of the metabolic story behind type 2 diabetes. We know that when we're preparing foods, different grains exert different effects in terms of glycemic control, but even within a recipe, porridge versus overnight oats may also have a different glycemic effect. And so staying on top of different recipes and ideas where your clients can use whole grains in their diet is really important. And it's less about worrying about just one factor, but it's about looking at that timing, the amount of food and the distribution across the day, but also the quality of grain that they're consuming. So, and as Kevin said, looking at serve size and portions. I have a lot of tiny ladies that come and see me, 5-foot ladies. And often what we need to do is really adjust the amount of food they're consuming right before going to bed at night. There's this tendency to have a really large meal before going to bed. And in that way, looking at amount, timing and distribution of carbohydrate across the day is one of our more powerful weapons. So there's no need to increase energy intake by making the swap to whole grain. It's about making these simple swaps. And this is actually one of the Oldways resources with looking at the amounts of whole grain that could be consumed in a serve. We need to keep those core foods central to the diet. And in many diets globally, we know that discretionary food consumption has really increased. And in Australia, I know that it's up around 35% of our energy intake. Whole grains are a really cost-effective measure, so we don't need to be concerned about socioeconomic status and the recommendations we're making here, which is unusual in nutrition because often a lot of our recommendations can be more expensive. And I think we need to be increasingly cost conscious for our consumers. We need to be aware that with some simple selections at the shelf in the supermarket, some bread products, for example, can be very high in whole grain and in just 2 slices can actually meet that whole grain target that we use, at least in Australia and in the US. And remembering that gluten-free whole grain products are also available. We know that a lot of clients who have celiac disease or the related conditions are often cutting out grains in their diet, and we need to get those back in, and the gluten-free grains are a particularly handy way of doing that. When we've looked at the Australian market, and it would be similar, we know that many breakfast cereals are at least a serve of whole grain. Something like 67% of breakfast cereals here are at least a serve of whole grain. 25% of breads are whole grain, 66% of grain-based muesli bars, flour products, savoury crackers. There's a whole range of foods available, and it's about knowing those food brands so you can recommend a whole range of products to your clients. In terms of policy, we need this to change. We need some impact, and we're going to use this healthcare cost saving to really deliver change at that political level. We need greater recognition of whole grain and the power it has within a whole dietary pattern. We need really clear and direct dietary guidance. In Denmark, they use choose whole grain as a very simple dietary guideline, in preference to really soft and fluffy language around preferably or mostly. Consumers don't get it. We need to be very direct when we're wanting them to make a dietary change. The inclusion of whole grain on front of pack labelling is also interesting. In other countries around the world, they have Nutri-Score. We have Health Star rating. But what you'll notice here is even with a white bread, compared to a wholemeal bread, which would be whole grain, they get the same Health Star rating, a star rating of 4. And so it's disappointing when we see this on shelf, because really we need to be able to shout from the rooftops for consumers at that supermarket shelf to really select whole grain, and using things like the Oldways logo is ideal in the US. We need to teach our consumers how to spot whole grain, but it doesn't necessarily need to be 100% whole grain product. We know that products, even with just 25% whole grain, provide a contribution across the day. And like other nutrients that we're consuming, taking in whole grain across the day is actually ideal for the human body. So at breakfast, at lunch, and some at dinner, thinking about snacks, and using that food supply system that has done really well to provide a whole range of products over at least 7 different food categories. So where to next? Even in countries where intake is low, there are significant savings in terms of health outcome benefits, but in dollar savings to increase whole grain intake, swapping it for that refined grain. So for our clients, really just changing bread, looking at that breakfast cereal aisle can really help consumers meet that whole grain target. I particularly like the Canadian plate. It really just features whole grain products. It represents food in a really delicious way, which is really what we're all about, showing our clients how to do this and really enjoy their food. Just like to thank you for your attendance today, and it's great to see so many of you online. I do have my references included with the presentation, and I'm going to hand back now. Thank you.
Thank you so much, Sarah. As both Kevin and Sarah alluded to, tomorrow is International Whole Grains Day. So there will be a webinar tomorrow morning. This is at 9:30 a.m. Eastern time, I believe. And so if you'd like to register for this event, you can go to the website below. It's wholegraininitiative.org/wholegrain day. And that will be a little more sustainability focused, and also some good policy discussion as well. So thank you so much, everyone who put in questions, and thank you to our speakers, Kevin and Sarah, as well as to the Bell Institute. Before we get into your questions, I do want to address some of the housekeeping questions that have been coming in. So you will receive an email within 1 week with your CPEU certificate, as well as a link to the recording and the slides. So keep checking your email within the next week or so. We're usually pretty quick, so it should be less than that, but that's how you will get it. And with that, I think we'll just dive right in. Thank you both.
Kelly, can I make one comment that's useful? Sarah had pointed out when she said that our numbers differed between diabetes, and she is correct. I had reported and misreported it as diabetes. It's pre-diabetes and type 2 diabetes that I reported in the number on my first slide. My apologies for not clarifying that better. So thank you for pointing that out, Sarah.
Thank you both. And yeah, I think we did get a question that came in about the blood glucose ranges and what those looked like. So I think that's helpful for that person as well. So I guess to get started, Kevin, earlier in your presentation, you presented information from the Nurses' Health Study about the whole grains they were eating and their risk of developing diabetes. Do you know what the racial makeup of the studies was, or if there was any social determinants of health considered?
That is part of the study. I did not go into that much detail for the purpose of the presentation being very limited. The study itself, if the person that wants to wait, I can provide that reference to them. It would have that information. But yes, when we look at a population of a study that includes nearly 200,000 people, it's not going to be nationally representative like we would see in NHANES, where they specifically test parts of the population that represent the broader nation, because this is the Nurses' Health Study. So as a result, they're looking at healthcare professionals in many ways, but healthcare professionals are going to be from a variety of ethnic and also socioeconomic backgrounds in many cases. So it is going to have a little bit narrower of a focus, and it, as I mentioned before, would not be nationally representative.
Thank you. Sarah, we have a question. Do you have recommendations on how to convince people to try whole grains? This person works with a population who grew up on meat and potatoes, and their clients are sometimes resistant to trying foods, some of these whole grain foods. So what is your advice?
I actually, I would have a similar population here in Australia. We're also meat and potatoes. I think that one of the key things I explain to them is actually about the global burden of disease. And because there's a lot of misinformation in the media and a lot of focus on sugar. And so I talk to them about how salt is actually the biggest issue. And the second biggest issue is diets low in whole grain. And I talk to them about how we can make up the diet. And there's some really great tasting foods out there now. From whole grain pastas, breads, cereals. I just really make it really practical and reassure them that it's these sort of small changes that help to move them towards health. It's really about, I think knowing the food yourself and being really confident that this way of eating is, easy to do, but also really delicious. And I think, we forget sometimes around the taste and texture of different foods. Even things like brown rice can add a real nuttiness to different meals. So that, normal fried rice that they perhaps make for an easy meal with some vegetable in there and some omelette can be made with brown rice, and it actually separates nicer and makes a really, really nice tasting meal that's got a point of difference.
Thank you. Yeah, there was a good article in America's Test Kitchen about stir frying with brown rice and how the grains don't clump together as much, so you don't need to add as much oil.
Yeah.
Kevin, are there advantages to cracked whole wheat products versus traditional whole grain processing?
I think it depends on what we're trying to accomplish. When we say cracked whole wheat, the wheat berry itself is literally just broken. It's crushed in half, but the nutrition of that may not necessarily be present then. So would you have more starch being available? No, the cracked will prevent that because the bran around there is going to prevent the starch from being as bioavailable. But as mentioned before, unless we can actually break some of that up, much of the nutrition from the whole grain could pass through the body undigested. It's very similar to people who eat like flaxseed. They recognize that if the flaxseed is not actually broken down, it can pass directly through the digestive system because of the lignin coating, very similar to what we see with the wheat berry. If that coating is not broken and made available for digestive enzymes, you cannot get the nutrition from it. So yes, because it's cracked, you'll still get some, but it'll be less. And if you're trying to control blood glucose, then maybe that's a good thing, but you're missing out on all of those components that you heard described by my colleague with that nice graphic.
Thank you. Sarah, we're getting a lot of questions about working with patients who have celiac disease.
Yeah.
Do you have tips for, gluten-free products or gluten-free grains that you like to recommend?
Yeah, so look, there's around about 7 or so grains that are gluten-free. Some of them are more available in the food supply system than others. So you've got buckwheat, you've got quinoa, corn, amaranth, teff, sorghum, and of course brown rice. And I often recommend black rice as well. So mixing it up there, and we have some great products even that are quite consumer friendly or convenient. Mixtures of quinoa and brown and black rice together in microwave type packs, so they're quick cook if people want them for lunches. The main thing I'm trying to do is keep that dietary fiber up, because we know often that gluten-free products are much lower in dietary fiber, and as far as I'm concerned, we've got 100 years of dietary fiber research. It rules the world, right? And it's part of the reason why whole grains are a big part of this story. It's not the whole story, but really focusing in on whole grains that are gluten-free. There are some questions now more recently around oats. And I think as clinicians, we need to keep our eye on oats because there may be some celiac clients that can tolerate oats, and it's more about a contamination story. Here in Australia, where we grow lots of wheat in adjacent fields to oats, we've got to be very careful. But there are some companies emerging that are producing gluten-free oats. And so keep your eye on that research. I'd encourage you to read more around that. But if it's an opportunity to plug legumes as well, because that was part of my old job at Grains and Legumes, I also make sure I get legumes into the diet, because they're really key food in terms of dietary fiber. And where we see particularly celiac disease hanging out together with diabetes, because often the two are connected, we do need to look at glycemic control. And so some of the higher GI gluten-free products can really benefit from having been combined with some legumes within a meal.
Thank you. Yeah, we like to say at the Whole Grains Council that gluten-free doesn't mean grain-free. And I think people are surprised, when they consider all these really interesting grains that might not have been part of someone's plate before, but they can sort of learn to discover as they journey into this new way of eating.
And a lot more are available in mainstream supermarkets now, which is great to see.
Yeah, definitely.
It's not just health food shops.
Kevin, I know there was a couple questions you wanted to get to. Would you like to choose the question you most wanted to answer?
Oh, why don't you just go ahead and pick one? By the time I got back on that one, we might waste a lot of time.
Okay, sounds good. Can you briefly explain the difference between glycemic index and glycemic load, and how processed or refined whole grains will differ compared to unprocessed whole grains?
Great question. Sorry if that wasn't clear before. So glycemic index is determined by measuring 50 grams of available carbohydrate in people over a 2-hour period. And they plot that out into this curve, and they determine on that the glycemic index of the food compared to glucose, like a pure glucose drink. So if it was like a gram of, a slice of a well-known white bread, won't use any brand names, a well-known white bread, and they consume that, that starch is going to be very available. Blood glucose is going to go up very quickly. So that would give you a glycemic index as a percentage of pure glucose. Glycemic load is a function of the serving size. So you could have something that is 100% pure glucose, but if the serving size is like a lozenge or something like a candy that's very small, then honestly, that's not going to make much of a difference. Where you would want to be careful is if you had something that had a high glycemic load because the serving size was very big and it had a high glycemic index, and that person is actively managing diabetes where they have difficulty. They're using insulin or other medications. So therefore, glycemic load is a function of glycemic index, but it represents how big the serving size is of that food.
Thank you. And thank you again to both of our speakers and to the Bell Institute of Health and Nutrition at General Mills for bringing this session to us. And stay tuned. We'll post this recording and slides on our website, and you will all get an email within 1 week. So thank you for joining us, and goodbye.